Bismillahirrahmanirrahim. Dear audience, today our topic of discussion is about childhood myopia. Myopia is turning into an epidemic. It is mostly because of the new lifestyles. Children are having more screen time and less outdoor activities, and more children are getting involved. And if I say it is turning into an epidemic, I will not be wrong. New treatment modalities are coming, but particularly regard the treatment of myopia by atropine eye drops, we will discuss today. Our guest speaker today is Dr. Carla Lanka. She is a research associate at New York University, Abu Dhabi. She has basically an orthoptist and she has done PhD in public health. She has extensive experience in research, teaching, and she has also served in Singapore Eye Research Eye Institute. And currently she is supervising masters and PhD students. So as this is her subspecialty, that is myopia, binocular vision, strabismology, so we invited her to please present his talk. So without further delay, I will request Dr. Carla Lanka to please present his talk on this topic.
First of all, I would like to thank for the invitation to be here today to present on this very important and interesting talk, which is the role of low-dose atropine in the management of myopia. And of course, I will focus my talk on management in children. Those are my conflict of interest, which are not related with the topic of the presentation. So today we are talking about atropine, which is a muscarine antagonist. It's used to slow myopia progression. We have many years of research related with the use of atropine in myopia. However, although we have a lot of research, we don't know exactly what is the mechanism. So we don't know the mechanics exactly, but we know that there are several hypotheses. One of them is that involves retinal pathways affecting the sclera. We also know that the most used concentration, it's 0.01%, is widely studied for its safety and efficacy. However, there are evidence from clinical trials that suggest that myopia, it is in fact reduced when we use atropine in a dose response manner. However, there are also other findings that have not been so consistent. So today, the aim of my presentation will be to highlight those studies and then try to understand from those studies what we can implement or how can we interpret that for clinical practice. So moving on to what we know so far, we have this very important study, which is the study from ATOM from Singapore. And as we can see from the graph, this was one of the first groups determined that 0.01% atropine was the concentration which was important in terms of efficacy, but also related with adverse events, which were many using this concentration. So as you can see here in the graph, we can see different concentrations. And as you can see here, 0.01% in the graph shows the better results. However, many years after this study and very recently, the authors were able to look into the results of the children that were treated at this period. Children were treated for 2 to 4 years of treatment with concentrations which varied from 0.01% to 1%. And it was interesting to see that when they see those in adulthood, although they were not able to collect data from all, but they were able to collect from 1/4 of this original cohort. And when they looked into the data at different concentrations, they found that there were no difference in terms of the final refractive error. Another thing from this study that is important, is an important takeaway, was that they looked into incidence of complications, and they found no difference in terms of those groups. So looking at the results of this study, it seems that this idea that we have to treat for 2 to 4 years may need to be extended, and these children may need extended therapy and being treated for more years. But of course, we need more research to support those thoughts. Let's look at another study. the LAMP study. They already have 5-year results that were published, and they also have more data that's going to be published soon. I will talk about that in my next slide. But here, the authors looked into the efficacy of different concentrations, and they determined for an Asian population, it seems that 0.05% is the one with better efficacy. As you can see, the study is for 5 years, but they tried to cessate the therapy at year 3. And as you can see from the graphs, after year 3, most children had to be restarted on the treatment. They also found that the ones that continued the treatment with 0.05% had good efficacy. They also have this group that you can see here, which was the group that restarted therapy. And as you can see in terms of the profile, they look almost similar. So looking into the results of the LAMP study, it seems that it is important when we are in clinical practice to reconsider, retreat those children if they start progressing after we cessate the therapy. So I was saying that there is more data. LAMP study, they already have data for the 7-year. For this study, they were looking into optimal treatment cessation strategy, which is also something that we need to know in clinical practice. We don't have the results published in a manuscript yet, but they presented the data at ARVO at the conference. And what they did was they looked into the groups that were receiving 0.05% atropine for 1 year. And they stopped atropine in this group. So this is called the stopped group. And also they had a tempering group. So in the tempering group, they received atropine, the same concentration for 6 months. And then they changed the concentration to 0.025% for another 6 months. Then they looked during the cessation phase to all of the subjects in the study. So when they looked into and compared the groups that stopped abruptly and the groups that had tempering, it seems that tempering treatment is better. But of course, we need to see the full results of this paper published yet. So this is preliminary results, I think. So another important thing to report is that more and more studies that are coming from white populations, from Europe, from USA, from the Atom Australia, they are seeing that they are not seeing significant results, at least for the Danish trial, where they used 0.01%. Also for the USA study, as you can see here from this graph. And at the right and here at the top, we have the data from Australia, where the effect seems small and then non-significant when they reach month 24. There's also data from the CHAMP, where they collected data from North America and also Europe. So in this study, they found that 0.1% atropine is better than 0.02%. So there was no dose response effect on this study, which is different and not expected if we looked into the previous results that we have been seeing. I also brought the results from Mosaic. So Mosaic 1, it's a trial in Ireland. So they only find modest clinical effect, if you see here, not for both outcomes. So it was not significant here for myopia progression, but it was for axial length. The authors in another paper also report choroidal thickness. And as you can see here for the choroidal thickness, it's interesting to see that for choroidal thickness, they found that there is a better results for the treated group, which is this one in blue compared to the placebo group. And why is this important? Because we know that choroidal thickness is related with the risk of myopic maculopathy. So this may also hint that we should also look at other parameters and not only to myopia progression and axial length progression as well. Although we know that the role of choroidal thickness is sometimes more variable. We also have data from Mosaic 2. And for Mosaic 2, what happened was that the group started all the children that were on placebo with a higher concentration of atropine, 0.05%. And they found significant results for myopia progression, but also for actual elongation. So this seems to be telling us a story that significant effect is found when we are using higher concentrations. It also seems that the results of these new studies are supporting that we can use higher concentrations, not only in Asians, but also in other populations. There's also an interesting study from Spain. This is a study with 5-year results. And contrary to what we have seen in Europe, for these 5 years, the authors found that 0.01% was effective for both outcomes. So perhaps this is also related with the time that we treat the children or the duration of the treatment. So it also may be related that we need more time and we need extended therapy to get more efficacy results. So here I've showed this study where there was a comparison between efficacy and safety of 8 atropine concentrations, which you can see here on graph A and B. The most important takeaway of this study is that they found that there are 3 concentrations that are most beneficial from myopia control, which includes the higher ones, 1%, 0.5, and 0.05%. There's also new results from the Cochrane review, which reports on intervention from myopia control. And this is a living systematic review that is going to be updated as more studies are coming. So as you can see here from the results, low dose atropine was considered very low certain evidence. And if we look into the high dose atropine, it was considered moderate or certain evidence. And we also have the results from actual length. So it's going almost to the bottom of this graph in terms of efficacy. However, we know that there are many factors that influence efficacy, and sometimes not all the factors have been controlled. So we may see differences because we are looking into different populations, not only the ethnicity, but also iris pigmentation, as we know that these darker irises have more melanin, and this can influence the results. We also need to have in consideration the age. So if we have older children, then we will see less effect. There is lower progression in older children as well. But there's also another factor that has been discussed, and there have been some letters and some authors and clinicians talking about the formulation of the atropine and the content, the pH, the preservatives, and the compounding inconsistencies that have been found in some of the atropine formulations, which may also lead to less effective results. We also need to consider adverse events. So we know that there are common side effects. They appear when we are using higher dosages, such as photophobia, blurred vision, or glare. But when we use low dose atropine, such as 0.01%, the effects are minimal. And there's also some reports saying that there are inter-ethnic differences. For example, some report that Chinese children, they tolerate higher doses better. And there are more side effects in non-Chinese populations, especially at higher concentrations. But we know now from the study from Atlas, which has a long-term results in terms of safety, that there is no increased results in terms of cataract or ocular complications on those children that they were treated 10 to 20 years post-treatment. So there were no systemic adverse events, which is also important in terms of safety for our patients. I was also trying to find more data that can be not only from Singapore, East Asia, but also Middle East, and more for the region where we are here. We don't have many studies yet. This study that I found interesting is a study from Iran. So as you can see here from the graphs, they had a placebo group. They had a group with atropine 0.1%, and 0.01%. So 1 drop per night for 6 months. So the authors found that atropine was effective. However, they saw this rebound effect that you can see from the graphs when they stopped the treatment here at 6 months. And you can see SE over here at your left and AL here at the right side. So although they found that they were effective, when they stopped treatment abruptly after 6 months, then they see this rebound effect, which is also important for us to know how we can deal and reduce this rebound effect. So there are some studies reporting the rebound effect, and there is a meta-analysis that included 13 studies, 2,000 over children. So they found that this rebound effect is more pronounced if you treat the children for shorter periods, 6 months post-treatment, than if you treat longer, for example, stop at 1 year. They also found that the risk is higher if you have a younger age or if you have a higher baseline spherical equivalent. And on this paper, the authors suggest things that we can do to try to mitigate or to reduce this rebound effect, such as gradual tempering, so stepwising the cessation, or there is also this new discussion about combining the treatment with optical strategies, such as the new anti-myopia spectacles, or any other, such as contact lenses, for example, as well, that also can be used. It's also important to know that it seems that there are about 10%, in some studies higher, children that are non-responders. This is not a characteristic of atropine alone. Other studies also report similar rates in terms of non-response. So there are some children that don't respond as well as we expect. And the children that may respond or have bad response are usually the ones that are younger, they have higher baseline myopia, and they have parental story of high myopia. And of course, as I was saying, there are many studies reporting on the progression of those children. And in those cases, there are a few things that we can consider. There are some already talking about increasing, instead of using only 1 drop per day, twice daily. But of course, we need more studies to confirm that this approach really works. Stepwising the dose in terms of stepping up, so increase the dose, or consider combination treatment for those cases where we have high risk of progression. There's also other in another line things that we can do in terms of myopia prevention, and especially treating pre-myopic children. This is maybe a controversial topic, but there is this meta-analysis showing that if we use low-dose atropine in pre-myopic children, then there is a significant reduction of the myopic shift over time. And this can be shown by this forest plot. So in summary, we can see that atropine seems to be effective. The effectiveness seems to be related with the dose, and higher dose more effective. It seems that the ones that are being treated with lower dosages, for example, 0.01%, about 20 to 30% may benefit from higher concentrations. And this is, as I said, related with age and history, parental history, and higher progression. It seems that rebound is less common in all children and with lower doses. And of course, if we are using higher concentrations, we need to take in consideration that those children may require photochromatic glasses, may require reading ads, and of course, the rebound may be more pronounced, and we may consider tempering for these cases as well. And also it's important that we take in consideration that 10% of the children may respond poorly to any of the doses that we have discussed before. So this is well explained in many papers. I've reported some of this, but also there is a myopia consensus statement that was released a few weeks ago and resumed and summarized all of this information for those that are interested in this topic. So just to conclude, just to talk a little bit of all the challenges and considerations. For now, there is a big discussion between the differences that have been found in terms of activities between Asia, Europe, North America. And I think to reply to all of our questions, we need more data. So we need data from different populations. We also need more data from the UAE, Saudi Arabia, and other regions in the world that can input more information about effectiveness in those populations. And we need to consider dosage, duration, and of course, in Asia, there's more discussion on dose tampering and the rebound mitigation, while in Europe now we are focused more on effectiveness in safety. But also we need to take a look into regulatory and access issues. So in many countries, atropine is used off-label, and there is a variable availability, and the cost may also influence decisions. So I want to thank you all for your attention, and I'm leaving here this QR code if you want to know more about my research, and you can also contact me on this email. Thank you so much for your attention, and I'm available for questions.
Well, thank you, Dr. Carla. You have explained in great detail about the myopia and its treatment with the different strengths of the atropine eye drops. And I have a question that what is the specific age which you feel that the treatment should be started in kids? And also, please tell if we are using low dose atropine eye drops, what is your suggestion and protocol regarding tapering of the low dose atropine drops?
Okay. So in terms of the age, the studies that I've been reporting here on my presentation, most of the studies are done in children from 6 to 12. So I would say this is the ideal group to start the treatment. And of course, we need to consider the cutoff of myopia. So usually we start treating around minus 0.5 diopters. And there's a bit of a discussion now if we should wait for the child to progress or not. I think most will still wait to see if there is a story of progression, at least for the last few months. So if we find that there is a progression of 0.5 diopters over the last 6 months. But there's also a new discussion because there are new methods available to treat myopia. And because we know that many children will progress, if we should start earlier than that. I mean, start treating even if we don't see significant progression. But I think this discussion will still continue until we have more data. And regarding tampering, I think in terms of the tampering, the LAMP study results will be very important when they are published because they seem to show that it's better to taper the dose. Of course, this is also related with age. So if we have an older child that is progressing or almost not progressing for a few months, and then the age is already at the adolescence, then I think in those cases, tampering may not be as useful. But if we have younger children with higher concentrations, and they are also, we need to consider tampering on those cases. So in the LAMP studies showing that tampering seems to be essential. So in their case, what they did was for the children that were treated with 0.05%, they reduced to 0.025%. So that's the strategy that they use. But I also want to highlight something that is important, that we don't have many studies on tampering strategies. But it seems that when we stopped abruptly from one day to another, then we see a higher rebound effect. So I think temper is essential, and depending on the risk and the age of the child. And I'm not sure, but for all the children, maybe not so much. But of course, I don't have the data to support that.
Yes, Dr. Lanka, you explained it in very detail about it. One more thing is that the treatment of the kids with 0.01% and 0.05%. One thing about what are your recommendations? And second, what is the efficacy of the treatments between Asians and non-Asian kids?
Okay. So from the studies that we have been seeing now, comparing the concentrations 0.01% and 0.05%, it seems that 0.05% it's better than 0.01%. However, there are some discussions about this approach, and 0.01% may still be important, especially if we have a child with a lower progression and older child. So in that case, it may be also an option. It may also be an option if you are using combined treatments, so combining with glasses, ortho-K, or other anti-myopia strategies, as we have seen some preliminary results that show that combined approaches with that concentration are also useful. And the other question you had was I think I replied to both of them. So it seems that mostly Asian children are responding, at least for atropine, responding differently. However, we still need to have more data to support that. My group are also looking into a review of differences in atropine in Asian and non-Asian. It also seems the effect a bit stronger in Asian populations. But I mean, we need more studies with more diverse populations to understand those results. But so far, I think from what we have, we can consider both concentrations looking into high risk and low risk patients.
Right. Well, Dr. Carla, when we talk about the low dose atropine eye drops, what is your opinion about combining it with other treatment modalities for myopia control? And how much you see that if we make a combined effort to control it, how efficacious is that one?
So there are some studies showing that it is effective if you combine with orthokeratology. There's also some studies showing the effect on soft contact lenses. Although there is one study from the Israel team that with 0.01% and was not able to find advantage of a combination, but when they use a higher dosage and another soft contact lenses, it seems better. But for ortho-K, I think we have more studies. There's also new studies from Italy with the new anti-myopia spectacles that shows that, although non-randomized studies shows that it seems better to combine 0.01% with spectacles. So it also seems to be an advantage to use combined therapies.
Right. Well, Dr. Carla, thank you very much for your time, and you really explained it in great detail about myopia with different graphs and charts, the different strengths and their efficacy and the rebound effect. And on the behalf, I know you have just come from international conferences, and I'm on the behalf of my audience and my channel, I want to thank you for educating us and giving us time on this very important topic, because nowadays more and more children, because of different lifestyles as we used to have at our time, they have more screen time. So it is turning into an epidemic, I think. So I really want to thank you on the behalf of our audience. Thank you, Dr. Park.
Thank you so much.